I appreciate the chance to be able to work with the Hope and Healing Center. I've been able to work with Dr. Stanford and the group there for several years, and it's always been great to work with an organization that has such a huge impact on mental health in the Houston area. So as Cody said, Dr. Elil Yuvarajan. I have a private practice along with my wife in the Webster area. So let's get into the presentation. So the things that I'm going to talk about today, we're going to talk about coronavirus and its impact on suicidality. All right. So what we're going to talk about is initially suicide and its impacts prior to COVID. We want to lay a foundation so we understand how things are changing, and without understanding the earlier foundation, that can be a challenging thing to do. We also want to talk about what has happened with suicide during COVID, and there's good news and bad news when it comes to that, and I'll kind of talk through those pieces of it. And then finally, because there are quite a few people who are in mental health treatment in this group, I want to talk about caring for others and how that works within this pandemic that we're in, right? I'm sure you've heard the words unprecedented times again and again, so I'll try not to beat on that dead horse, but I do want to say this is obviously a different experience. So that we're having now, just the fact that we're doing this via web as opposed to often face-to-face shows some of the changes that we've all gone through during this time. So looking at the foundation of suicide and suicidality prior to COVID, right? So the annual suicide rate is 14.5 per 100,000. Now, that in itself is not necessarily a useful number. The important piece of it is what we look at the trend, right? So it was 10.4 per the same number in 2000. So over the last 20 years, it's gone up pretty significantly. And that makes a huge impact, roughly 40% in terms of the area we're heading into. So as it's been rising steadily, this is the context in which we enter the situation with COVID. Suicide is the 10th leading cause of death in the US across all age groups. For teens, that tends to be, for ages 10 to 34, it's actually the second leading cause. And for people the ages of 35 to 54, it's the fourth leading cause. So there's quite a bit of variation in age groups as we look at this as well, which is an important thing to pay attention to. 78% of completed suicide are by males. Also, one of the things that's important to recognize is that people in marginalized communities tend to have higher rates of attempted suicide. For example, in the LGBT community, the rates are 4 to 12 times higher, depending on the study you look at and the specific group within that. Over half of suicides are via firearm. Then we go into other areas such as suffocation, poisoning. So there, and that falls into the trends that we'll talk about and how that we'll approach that piece of it. So more than half of suicides have also been previously diagnosed with some sort of mental health issue, and over 90% of people tell someone. So again, think about this in the context of what we're heading into. The majority of people who attempt suicide have been diagnosed and are often in some sort of treatment for mental health. And then more than 90% tell someone. So ideally, we would like this to be someone who's in the mental health care field. So we'll talk about how we facilitate that. The final piece is, unfortunately, the bad news with looking at some of the suicide issues around COVID is that there is infrequent reporting. So we don't have regular live reporting of suicide rates within the United States. All of what I'll be focusing on today is the United States primarily, only because as we go across the globe, you'll see significant changes in how it's approached. So what do we know from the past? First, we look at previous pandemics. They've always been associated with increases in suicide rates. So for example, we go back to the Spanish flu, which a lot of people have obviously been talking about and comparing to COVID and what we're going through, and rates of suicide increased during the Spanish flu and after. Hong Kong, during the 2003 SARS outbreak, also observed an increase in suicide rates. And during Ebola, people in Africa experienced an increase in suicides during the Ebola pandemic. One of the things to recognize with these, so for example, with Hong Kong, there was an increase in suicides among the elderly population primarily. That was a group that was most highly impacted. As we look at some of these other groups, what we notice is that in the past, suicidality affects marginalized communities and minorities, the elderly, and emergency medical workers most severely. So as we look at the trends, those are the groups that are highest at risk based on past, and also talk about some of the current research and what that will show. We do have some early data associated with COVID. And what it shows is that there's statistically no difference in overall rates of suicide prior to COVID and during COVID. However, I'm going to add a caveat to that. This is based on early levels of data. If any of you have published peer-reviewed papers or published anything, you know the process for going through that from the time that you propose a study, collect the data, get it approved, submit it, have it reviewed, all of that takes several months. So along with the fact that current suicide rates aren't published, we also run into the issue that the process of publication, especially peer-reviewed publication, takes a long time. So a lot of the information that we have is preliminary, and we'll find out more information. Unfortunately, a lot of this will come several months after a lot of people have been vaccinated and treated. Studies from Maryland, England, Australia, and Norway have supported this idea. And they've also supported the idea that some populations may be more at risk than others. For example, elderly youth in a study in England have shown higher risk, racial minorities, the unemployed, mentally ill, and health workers. Again, similar to patterns we've seen in prior epidemics. So it's important to pay attention to these vulnerable groups as we focus on where treatment needs to be addressed and prevention needs to be addressed. The other area we look at outside of epidemics in the past is also natural disasters. So whether that's Hurricane Katrina, Harvey, these are natural disasters. And often the pattern that we see is a short-term decrease followed by a later increase. Now, why might that be? Take a minute to think about that. So why immediately after a natural disaster might suicide rates drop, and then later on is when suicide rates might go up again? The idea, the theory that's proposed is that immediately after or during any sort of a natural disaster or epidemic, people pull together. That's where there's a lot of social support. There's an attempt for people to reach out, help one another. There's an attempt by people to focus on the things that absolutely need to be done currently, whether that's going out, getting grocery shopping, getting supplies, things like that. They're things that people can actively do, and that fulfills a sense of purpose. As people go further into it, right? Fewer people pay attention, fewer people check in with people that are impacted, and over time, people become more isolated and feel like they're alone in what they're going through. And we're seeing similar things, at least from my day-to-day experience as a therapist in this field. Japan study also shows this trend with COVID. So initially, the rates were lower pre-COVID, and now the rates are higher as a result of that. The study particularly was done in October, right? So now, if you look at the media, what a lot of the media will focus on is the fact that the rates are higher now. However, it doesn't tell the full story. Right? The other piece this also supports is the idea that in Japan, women and children and adolescents had a higher rate of suicide afterwards. So it didn't come back at the exact same rate for all the people that had been impacted prior. It came back at a higher rate for some of these more higher risk group that we've talked about. So let's look at some of the mental health issues that have been summarized. So although we can't necessarily study the the suicide rates on a live basis, what we can look at is how COVID is impacting mental health overall. So again, what we find is that almost half of people, 40% of people, have at least one adverse mental or behavioral health condition. So whether that's, a diagnosable mental health issue, whether that's just increased levels of stress, feeling trauma associated with it, all of these things have increased as a result of COVID. Specifically, anxiety disorder and depressive disorders have gone up 30%. Now, when you connect the idea that it's gone up to 30% to the idea that depressive disorders are the disorders that are most linked to suicide and suicide attempts, that's an important thing to pay attention to. Also, symptoms of a trauma disorder related to the pandemic. Almost over a quarter of people feel that. Of course, substance use to cope with the stress or emotions related to COVID. This has sort of become a joke online, but the idea that people are drinking and using more substances as a result of COVID to cope because they're not able to use some of the previous ones they were able to use is an important consideration in this process. And the percentage that's seriously considering suicide overall, regardless of whether they act on it or not, is over 10%. Again, that's a pretty significant number that are considering suicide overall. Majority of these are in the ages of 18 to 24. These are people that are often college age, early in their careers. These are more people that are more likely to be impacted by changes in the economy and the entry-level jobs that are eliminated during this process. Minority racial ethnic groups as well. Hispanic respondents, for example, are 18%. And then Black respondents at 15% in terms of people who are considering suicide. The other area is unpaid caregivers for adults. As social support decreases, or as people are isolated in their homes and are unable to go out and do the things they would normally do to cope, especially people who are taking care of adults, elderly who need assistance, the stress and anxiety that goes along with that increases. And finally, essential workers. As we spoke about before, essential workers, people who are on the front lines doing emergency medical work as well. There's an increased level of suicidality. There's an increased number that are considering suicide overall. Whether that's the hopelessness of not being able to help as many people as possible, as you saw in some of the early studies in New York, where the hospitals were overwhelmed, or in other places where hospitals are overwhelmed here in the US and across around the world. So of these people that are feeling this, the other piece that's important is that only a small percentage are reaching out to mental health professionals. So in the past, whereas roughly 40% would reach out to mental health professionals, one preliminary study in England, for example, showed that a significantly lower number, closer to 20 to 25% were reaching out to mental health professionals. So proactively reaching out is not something that as many people are going to do. The other thing that's important to focus is the idea that a trauma disorder is really important in considering this. If we think of COVID, if we conceptualize this as something that's a collective trauma, as opposed to just a health issue or something like the flu, that is an important thing in how we conceptualize and then how we work towards treating it. So in other words, like September 11th, we're all impacted by it, not always as directly, but based on seeing the news, the vicarious impact of these things is still significant. Here's another study that shows, so for example, young adults in 2018 to August of 2020, you can see the significant impact of that. So more than doubled in terms of the percentage that had seriously considered suicide during that time frame. And as you see, all ages as well, almost doubles for all age groups. So next, let's step into talking about suicide stressors that are due to COVID as well. So there are things that are frequently talked about in media, and I think these are the things that people are very well aware of these days. So economic stress, lost jobs, whether small businesses are struggling or even larger businesses, especially in the field of like retail. Also, parents staying home with kids whose schools are closed or doing at home learning is also an important piece of it. Right. So one of the things we'll talk about is a Google study that was done. I'll get into that actually in the next slide. So social isolation is another stressor associated with COVID. So people are not able to go to the areas that they would typically might go to for support. These include community and religious support, whether this is, for example, I work with a lot of people in substance abuse. So not being able to go to an AA meeting or an NA meeting or an Al-Anon meeting is significantly impactful for people who relied on these support groups as a way to maintain sobriety, as a way to maintain their health, mental health. Along with that, of course, religious support, people who are used to being able to talk to their pastor and process things that are happening in their lives. People who are able to go to church and find a community where they feel they can pray together, where they're able to get support in the things that they're going through is a challenging thing. Along with that religious support, we also have to consider the idea that for people where they've had people close to them die, funerals are not the same. If you've gone to a funeral, they're not the same as they were prior to COVID. It's limited in terms of the number of people that can go. If the person died related to COVID, often there isn't really even an ability to say goodbye, go to the hospital, view the body prior to them having to dispose of the body for health reasons. Of course, these adds to the feeling of isolation and the feeling that people aren't able to process grief in the same way that they were able to before. Decreased access to mental health care and healthcare in general. For those of you that are in the field of counseling and therapy or case management now, I imagine if you're still working, you have gone to the idea of telehealth. And a part of this has been a necessary part of how we function. Me personally, telehealth was a minor part of what I did, maybe 1 or 2 clients a month where they needed to access me through a video platform as opposed to coming in face-to-face. However, now closer to 90, 95%, even at this stage in COVID, are coming in as via telehealth. So there's a decreased access to mental health because not everyone was able to transition, and not every group is able to, mental healthcare professionals able to transition to telehealth as well. Certain things you're not able to do via telehealth, so that limits the access that people feel they can access at a particular time. Illnesses and medical issues, again, COVID is obviously the most obvious one, but then we're talking about a lot of the issues that follow post-COVID, whether those are neurological symptoms, ability to breathe, ability to just feel healthy, have energy levels afterwards impacted directly by COVID. But also, if people aren't going to the hospital to seek preventative care because they're worried about the types of things that are, they may get COVID from the emergency room or from their primary care office, that is obviously going to lead to issues later on. A big percentage of people who seek mental health and are in crisis go to the emergency room. They don't necessarily reach out to their primary care. It's not necessarily at a time where they can, so they go to the emergency room. But if they're afraid of getting COVID, if there's an anxiety that's related to that, they may not seek help, and that might increase the suicidality associated with that. News coverage. News obviously is talking about the impacts of COVID stressors, whether that's job loss, whether that's health issues, whether that's mental health issues. In fact, mental health issues are probably more talked about now than they ever were before COVID. However, what we're also seeing because of that is because suicide is sort of highlighted in these cases and individual things are brought up, people might have a misperception that suicide is a normal and reasonable option because there are other people that are going through it as well. Again, this is not a direct impact due to media. However, it can be an indirect impact in terms of some people feeling that it's normalized. Final piece of it, as you saw, firearms are the number one reason, or the number one method for people actively killing themselves. So firearm sales increased. right? So again, because it's the most common method of suicide, this is also something we have to watch out for because of the impulsivity of having a firearm in the house and feeling depression or feeling stressed and anxious in that moment and how that can relate. Majority of the people who attempted suicide, what we find, the number one thing they have in common is that they had a crisis in the preceding 2 weeks, or they felt there was a crisis that was coming in the upcoming 2 weeks, right? So if those people feel that there's something that happened or is about to happen and they don't see a way out of it, they're not sure how it's going to go, or they're waiting for the impact to still hit them, having a firearm in the house can lead to more impulsive suicidality. So it's again something we need to watch out for. Again, I'm very much restricting what I talk about as much as I possibly can to the area of suicidality, even though I know I'm touching on some of these other mental health issues, and which we obviously have to touch on. But there's some things I'm not going to be able to touch on as much. We could do a completely separate presentation of domestic violence, for example, and COVID, how domestic violence rates have gone up, the number of calls that the police are receiving for other crimes has gone down, but for domestic violence has gone up. And of course, things like that can lead to increased suicidality for the victims as a result of it, and less access to be able to leave, less access to support through the process of leaving as well. So again, something that's important to take into account is all these other issues that happen. The Google, I have a couple of questions that come in. Let me take a look at these real quick, see if I can answer these. Okay. So one question is, if more people are considering suicide, why has the rate of suicide not increased? Again, what we see is that just because more people are considering suicide doesn't mean we necessarily see that turn into active suicide attempts. One of the things we need to take into account, which I'll talk about in the next slide, is in terms of protective factors and how that can be helpful as well. The other piece I'll say is, we don't know, it's not linear, right? So we're not necessarily going to see a linear increase as soon as people go into quarantine, or beginning of March 2020, we didn't see a linear increase. However, what we need to prepare for is the idea that as suicidality and suicidal thoughts come about, even though they may not act on it immediately, some of these things may happen later, okay? So we'll talk about as therapists, or even with family members, people that you care about, things to pay attention to, how to address this when you see some of these things, warning signs that some of these things might be coming up. And I'll talk about preventative things and things that we can do. So again, although rates have not immediately gone up from what we can tell and the data we've collected so far, we may see that going up later on, and we want to do whatever we can to prevent that. Another question, how about people who didn't get impacted by COVID? Will that affect the suicide rate for being a secondary effect? And talk about that. And actually, I'll talk about that actually in a couple of slides. So I will get to that question. This particular slide talks about Google searches. Of course, you know, one of the things that we can measure mental health by is that people turn to Google to understand a lot of different things. So based on the searches that are going on in Google, it gives us an idea of the things that on people's minds, things they're seeking to understand, things they're seeking help for, right? So as we see, if we look at the words fear and worry and people's searches based on that, we see a pretty significant increase during the period of this study, which is again, January through the end of March in Google, which again, there's still a long period of time that's after that hasn't been studied, but this is important. Other studies on Google searches, even when people, there's been an increase in the search for the word suicide, for example. So that has been an increase in the search for suicide, also depression. But what we often see as the number one precursor to before people look at suicide, prior to that, we see people typing in Google searches for I lost my job, laid off, unemployment, and furlough, right? So those are really important things to understand. There are also people at the same time seeking out disaster services, right? So suicide hotline, not just suicide, but then ways to work through it, treatment groups, support groups. So It's not just Googling of the words, but it's also Googling of resources and potential support. Whether they access them or not, that's another question that we don't know enough to understand fully yet. Though again, preliminary studies show that people aren't reaching out as much as they have been in the past. There are also other queries about help seeking in general mental health that were moderately elevated, but not quite as much as some of the things that we mentioned there. Again, these are all warning signs. They give us a feeling for trend without having really solid numbers. The other piece that I said that I was going to talk about is suicide protective factors, right? Physical distancing versus social distancing are not the same things, right? So for people who are able and have access to technology, the web on a regular basis, one of the things that people have experienced is increase in being able to connect with other people via chat, via FaceTime, via Zoom, things like that, right? I, for one, have been to several birthday parties, baby showers, and things that were held via Zoom. So there's been a little bit of normalization of people's attempt to connect still, which is a really good thing to be able to see. However, as we see, there's certain populations, whether that's low income, whether that's the elderly, where they may not have access to technology or feel comfortable with technology in quite the same way to be able to do this. That's also going to be, we see that connection as well in terms of people being able to get vaccines, right? The idea that if you don't know how to do it yourself, you better have someone who has access to the internet, is comfortable with it, and is willing to spend several hours sitting there and trying to get you signed up for it. Although these are things that people sort of joke about to some extent, this unfortunately tends to be a very real thing. So people who are not able to access the technology aren't going to seek out telehealth options. So again, telehealth increases access for some. Personally, I have far more adolescents who are seeking help, and parents are seeking help for their adolescents. Part of that is since they're doing schoolwork from home, they have more flexibility to be able to see me. They can just step outside from a class for an hour and to be able to talk to me. The other thing is there are teens that are far more comfortable via online than they are face-to-face sitting in my office. So there's a different level of connection and openness that some people are actually experiencing. So to that point, people with social anxiety, there are, although, they will eventually have to re-enter society physically, there are people with social anxiety who are feeling somewhat of a relief in not having to go to school. For example, I see that in my teens predominantly, where when they struggle with social anxiety, they're actually doing really well being able to reach out to just the friends they want to online. So that piece of it adds sort of a supportive factor as well for some of these limited groups who deal with anxiety, especially related to social. Other types of anxiety obviously have gone up as a result of that, especially if you had, any sort of germ phobia, obsessive compulsiveness associated with that. Obviously, we'd expect to see some increases in impact on that. Right. So let's talk about sort of the most common patient reactions. Right? So initially, it's the first one we'll talk about is sort of the overt struggle due to COVID. So this is someone who's either been sick themselves, they've had a family member who's been sick or who's died as a result of COVID, and also we'll consider a direct impact to be either a job loss or significant financial struggle as a result of COVID. So what are typical reactions that we might expect from people who are in that particular group? So there's a sense of hopelessness, right? So they're sick, they're unable to seek help, for example, or they have family members who are sick and they're unable to go spend time with them, talk to them. Although a lot of medical staff are trying to help people stay connected, it's not always possible. So there's some sense of hopelessness, disconnection that can go with that. Second, of course, frustration, job loss, financial struggle at the same time for a long period of time. We saw the stock market reach record levels at the same time, talking about record unemployment rates. So people feel frustration as a result of that piece of it. And that can be sort of related to an overt struggle associated with COVID. And then, of course, the idea of any prolonged health issues and then treating it like you would a chronic health condition, dealing with some of the issues that people deal with that. The second category we'll fall into is indirect struggle due to COVID. So as opposed to directly your health being impacted, we could have that as being childcare. So for example, your children's school closes down and you have to stay home from work. You're not able to work the same hours. You have to quit your job, laid off, furloughed as a result of that. So childcare demands, right? Loneliness, missing family and friends, can be a really challenging and difficult thing when people are used to having social support, not only for people with children, but for people across the board. And again, that 18 to 24 age group, where there's sort of that really significant growth in socialization and forming these long-term relationships, there's definitely some significant damage that's being done within that group. How long-term it'll be, that's the piece we'll still have to wait to see. So with this group, it's frustration, right? It's, oh man, I don't have time to sit there with my kids while they're going through school and while they're doing online learning and do my job at the same time and go grocery shopping and do all these other things that I need to do. At the same time, the big difference we see from that first group is survivor's guilt. Right? There's this invalidation of their own experience. So, well, I'm having childcare issues, but at least I still have a job, right? Yeah, I miss my family, but at least none of them have died due to COVID. So I should be grateful, right? I should really appreciate the good things that are happening in my life as opposed to being frustrated and being, upset by this. So I'm not allowed to feel sad. So that's another common reaction. Right. And another group is sort of the denial avoidance piece of it, right? Which is whether that's COVID is the same as the flu, it's overplayed in the media, whether that's, I'd rather have my kids go to school and, since it doesn't really affect children, whatever the reasoning is behind it, there's the idea this isn't as big of a deal. And of course, then there's a frustration that goes with that, right? Like I lost my job with this thing that isn't even real, or I lost my job and I'm willing to take the risk and keep working here. So why aren't I allowed to? Some of these things, you definitely feel a frustration, not because of the direct impacts of COVID, but then as a result of the impacts that are on them, but without necessarily the survivor's guilt or the feeling of invalidating their own experience associated with it. So then we get to what can mental health providers do as a result of that. One is checking in on patients regularly. So if someone has been coming in consistently to see you, reaching out to them, right? These days, especially, we use a platform which is HIPAA compliant for messaging to patients. So, we message people typically only for, scheduling appointments. But during this time, sometimes we make an exception and go, hey, haven't heard from you in a while, hope you'll schedule soon. Or, hey, let's set up an appointment so we can talk soon. We don't necessarily address issues, but it's a great way for people just to feel like someone is reaching out to them, that someone is aware that they may be struggling in the moment. The other piece is to, if people are coming into therapy, seeing them in telehealth, face-to-face, whatever, is actively bringing up the impact of COVID. As we're getting farther away from it, I notice people are less likely to actively bring it up as something that's on their mind, though it may still be impacting them with all the changes and, whether it's mask policies or whether it's vaccine issues, people are still dealing with things associated with COVID. They're not necessarily bringing it up as much of a crisis way. So the other piece then is to normalize their reactions, right? Regardless of whether someone's been directly impacted, whether has been indirectly impacted, which I think has been the majority of it, or is in that denial phase, it's important to normalize their reaction. If someone loses their job, regardless of whether they believe COVID was real or not, it's important to validate the frustration they feel about losing their job, about their kids not being able to go to school, and the fact that they're not getting the socialization they feel they need, right? It's not the time necessarily bring up, well, at least they're safe, right? Well, at least let's look at the positive side and talk about the good things that are happening, right? Often people don't need that at that initial stage. So it's important to normalize whatever frustration and experiences they're having before we go into any sort of work on it. Okay? The other piece is a person-centered approach. So this addresses the question of, how about people who weren't impacted? How about people who, were significantly impacted? right? So a person-centered approach is important. There is no generic way to address a person as it's related to COVID and suicidality, right? Someone who's considering suicide because they're so frustrated that the government closed their job down is going to be, you're going to approach very differently than someone whose parent died and is considering suicide as a result of the close relationship that they lost. Right. So we need to take a very person-centered approach, right? And then we modify the treatment plan as necessary for that. We want to use our sort of standard suicide treatment, right? Which is to check in with them, talk to them about, suicide ideation, talk to them about intent, talk to them about plan, and then talk to them about kind of some of those specific experiences they're having. Often it's important to validate that thinking about suicide is sometimes a natural reaction, not definitely the actual suicide or attempting suicide itself, but feeling like life is hopeless is an important thing to acknowledge and validate as you would in any situation, even prior to COVID, right? Of course, outside of that, we also want to work on protective factors and things that are keeping them from killing themselves, or talking about COVID as, a temporary thing and what's it going to look like after? Do you think your job loss is going to be a permanent thing? Do you think there's any hope at the end of this? What will it be like when you get to talk to your family again, right? So we want to take a person-centered approach, but we want to direct it towards the type of thing that person is dealing with in that moment. The other piece I'll talk about in terms of that as well is the idea of some of these populations we talked about, right? So if minorities, LGBT populations, the elderly are more significantly impacted, we want to spend more time looking at the impacts on these populations and checking in to see how they're being impacted by it, right? For example, many of my African-American clients talk about kind of the racial impacts of COVID-19 and how there's a disparity in whether that's treatment, whether that's history of feeling like, history of being tested on with vaccines in the past and not feeling like that's something they want to take a risk on. These are important things to address and acknowledge, right? Again, a person-centered approach, but we have to look at some of these groups that are going to be more significantly impacted and make sure that we find a way to address the specific issues that they're dealing with, right? So, for example, with my African-American clients, it's acknowledging, this is affecting minority populations different. What's that like for you? How does that impact your willingness to get the vaccine or not get the vaccine? How does that make you, think about how you reach out to treatment, right? So again, it's important to bring it up. It's important to process it. People aren't always willing to bring it up openly. I think in some ways, for minority populations, I have an advantage in some ways of being a minority, bringing up those things or they feel comfortable bringing them up to me. But for people who are not a minority population, it's still important to actively bring that up. Right. So being a male, I may actively need to bring that up with female patients and say, hey, there's all this talk in the news about how women are being negatively impacted, stay-at-home parents, and how they're seeing the duties are being pushed more onto women, and along with having to manage childcare in their job and all these things. It's important to talk about those things and, hey, is that impacting you, or how is that impacting you? Maybe it's not. That's great. But at least you brought it up and have the chance to talk about those things. So again, the biggest thing is actively and proactively bring these things up. Again, I jumped ahead, but acknowledge the impacts on marginalized minority groups, right? You don't need to try to convince them whether they need to get vaccine, need to get help, any of those things. It's start with the idea of acknowledging where they are, meet them where they're at, and then give them an opportunity to then go to where they need to as a result of that. Right? Help facilitate accuracy in health information, right? This is a really important thing. So even though we may not have, depending on which of you is on this call, have a medical degree, it's important to still help facilitate accuracy in health information, or encourage people to look it up and process it and talk about it. even though, the idea of, oh, they're going to put microchips in my vaccine, all sorts of different rumors and things that are going on, it's still important to try to facilitate in as gentle a way as possible accurate health information, because we are medical professional, and though we may not push people to get vaccines, it's still important to help them process it and find accurate information. And I'll get to kind of places where you can find accurate information as at the end of this presentation in the slides. Empathizing with stress reactions, right? If I haven't lost my job, so I'll speak personally, right? And as mental health professionals, honestly, the demand for my services has gone up significantly, especially because we're offering telehealth, significant wait lists, people calling constantly. The amount of work that I'm doing has not decreased at all. However, that doesn't mean that I'm not allowed to suffer or have some struggle associated with it, right? I may still have childcare issues. I may still have just the idea that of survivor's guilt, right? Like, hey, I don't know anyone who's been impacted by COVID. I feel kind of guilty because I want to help people, or I don't really understand how this is impacting people. So again, when people invalidate their own feelings, right, their own experiences, and say, oh, I shouldn't be feeling this, oh, this isn't really a big thing, this is an important part to address at that level before it turns into something that at an unconscious level becomes more of a process about hopelessness or suicidality, or why am I feeling so depressed? I have no reason to, I should be grateful. And then comparing that gratefulness to the depressive feelings they're having, and then feeling like, well, is this ever going to get better since there's no reason for it, that, suicide might feel like more of an option in that moment. So again, meet people where they are and empathize with whatever stress reactions they're having, and it's valid to have those. Right? And then increase patients' ability to cope with distress. So whether that's through, mindfulness activities, whether that's through, teaching them skills that are going to help them cope with some of the things that are going on, just offering a friendly ear to listen to on a regular basis when they may not have access to their normal channels of social support. It is really important to be able to be there and be present with them whenever possible. Right. For children, teenagers, it's important to work with parents at the same time to be able to understand how are their children reacting in the time that they're not in therapy. Are they having any adverse stress reactions or things? How are their grades as a measure of negative things they may be experiencing? With children, depression, some of those things, as some of you may already know, doesn't come out as sadness, right? It comes out as irritability. It comes out as withdrawal. So we need to pay attention to some of those cues, right? And the final piece is to encourage social connection in whatever way is possible. As I talked about substance abuse and support groups earlier, for example. So encourage people to visit some of those online. There are several groups that have done a really good job of transitioning online, and there are several groups now that have opened up to face-to-face AA, NA, Al-Anon, Alateen, that have opened to face-to-face things, masks required. So there are opportunities to be able to get back into some of those social support. And if you have the ability, if you offer groups, then there's an opportunity to do that via telehealth as well, to help people have a feeling and that there are other people going through this, and help normalize some of those experiences. I think normalizing people's experiences through this, because, sort of like with 9/11, well, I wasn't in New York, I wasn't in Boston, I wasn't in any of these cities that was impacted, but I'm feeling really overwhelmed. I'm feeling very, stressed out by this, and I don't know why. Some of that vicarious trauma, whether it's through media, whether it's through just hearing someone's story secondhand, is still a really significant thing that can impact people. So encourage social connection, normalization of what they're experiencing. So that is predominantly the presentation. I do also, in this presentation, in these slides, want to provide some of the resources that are available. These are all as a part of that at a national level. So whether that's related to support specific to COVID-19, here's, often these groups are doing phone as well as text, which is really beneficial. There's also national suicide prevention. They're specific to some of these communities that need additional support during this time, LGBTQ, veterans, frontline workers, and then also Houston area resources. And finally, for folks that are counselors, talking to people who are struggling with these issues, let's not forget that it's really important to focus on the self-care of it so you don't get into a point where you feel hopeless and where you're ending up feeling more suicidal as a result. So there's a list of resources that are available for counselors, focus on self-care through this process as well.